Thank you so much for coming to our panel tonight this morning on medical ethics. I am so pleased to have such a wonderful panel of speakers today. I'll introduce them in the order that they'll speak. On my left, I have Stephanie Davies-Arai, who is the director of Transgender Trend and the author of Communicating with Kids. Next to her is Sue Evans, psychoanalyst, psychotherapist, co-author of Gender Dysphoria, a therapeutic model for working with children, adolescents, and young adults. Catchy. And also a key player in the Tavistock scandal. On my right is Jennifer Lal, who is the founder of the Center for Bioethics and Culture and the program director for GenSpect USA. And on her right, I have Dr. Margaret McCarthy, a GP, writer, broadcaster, academic, and at the University of St. Andrews. And then last, but certainly not least, on my far left, I have, is this left? Yes. I have Stella O'Malley, psychotherapist, director of GenSpect, author of What Your Teen is Trying to Tell You, and many other books too. So we're going to have a lot of discussion today. I'll introduce the speakers to speak each for 5 minutes, and then we're going to come straight out to you. There's a lot to talk about. I know that a lot of people here will want to talk about gender, but gender is not the only fruit. There's the opioid crisis, and when you start digging into this, there are scandals around HRT, around Tylenol, antibiotics. So there's a lot to talk about. So with that, I would like to introduce Stephanie.
So I'll go straight in. The WPATH standards of care were never like any other clinical guideline. The Endocrine Society recommended the use and does recommend the use of puberty blockers on the basis of low quality or very low quality evidence according to their own grading system. And they've had that since, I think, 2011. We've always known. CAS, after 4 years of an independent review, has found exactly the same, as we should have known. If it wasn't clear before, back in 2017, it became obvious that WPATH are first and foremost an activist lobby. And that year, the USPATH conference in Los Angeles cancelled the second scheduled talk by Kenneth Zucker, and he was the most experienced clinician and researcher in the area. After his first talk was disrupted by activists, he then demanded a meeting, and WPATH and USPATH bowed to the activists. His second talk was cancelled, and the board posted apologies. And if you saw the videos of the that conference's evening gala, it's typical of scenes that we see. Trans activists were celebrating their win, demanding that WPATH change, and that the standards of care change to affirm transgender identities as completely normal. And so the videos really show that this is no normal patient advocacy group. These are activists. There are parallels, I think, with the opioid scandal. In that case, a pharmaceutical company employed salespeople to conduct a hard sell of a painkiller they claimed was not addictive. And that's very reminiscent, I think, of the trans activist groups online and going into schools and directly targeting children to sell gender identity, the concept of gender identity to school children. In the case of opioids, they made up a new condition they called breakthrough pain, and they claimed there was a research study proving the drug was safe and effective. They told doctors that prescribing the drug was the only responsible way to alleviate their patient's pain. It was kindness to administer it and cruelty to withhold it. Where have we heard that before? And of course, there wasn't actually a research study that proved it was safe. And one of the parallels is that they claimed only 1% of people became addicted, which is like the 1% they say that the regret rate is. So you can see the parallels, but I think there is a difference that transgender is not a medical diagnosis at all. The word refers to a political cultural group, and it was founded on a belief in a kind of gendered soul. And it was created through social control, including the mass indoctrination of children and the silencing and punishment of any dissent. And this, I think, we haven't seen before. So affirming a girl as a boy or a boy as a girl was almost unheard of a decade ago. And persistence rates under the approach of watchful waiting, where children weren't affirmed and socially transitioned, were much, much lower. So there's no historic precedent for this, and the explosion in the number of adolescents, predominantly girls, suddenly declaring an opposite-sex identity. And I just want to take up one point from Cass, because she talks about the fact that social contagion is the most controversial idea, and she doesn't really go into it much. But she actually does include quite a lot about the social and cultural environment that this generation is growing up in, and how it's different to previous generations, and the ways in which it's potentially more difficult. And she mentions another social contagion that happened during lockdown, and that was the contagion of tics. So I've always felt it makes no sense. If we take just this group of the so-called rapid onset girls, it makes no sense to relate this group to historic cases of gender dysphoria. And it certainly makes no sense to link them with older heterosexual cross-dressing men. And the trans umbrella is not a helpful framework to use for this group. So we know that socially transmitted conditions or disorders typically disproportionately affect adolescent girls. And the sudden development of Tourette's-like symptoms among teenage girls during lockdown was linked to social media exposure. It was even referred to as TikTok tics. And it was understood that this was a social contagion. And can you imagine that anybody daring to refer to TikTok trans? In other areas, health, we're allowed to speak freely. We're allowed to explore the issues and see and place conditions where they belong. I think certainly the case of rapid onset girls and some boys as well belongs in the area of social contagion. What we know about that does not belong in the area of trans.
So I come from a clinical perspective on this, and one of the most important things in this area, in my opinion, is assessment, good assessment. It's ordinary good mental health work. And many of the people who experience gender dysphoria or trans identities do have a background of comorbidities, of mental health issues, of abuse. Some are struggling with their sexual identity or orientation. And certainly the kids need careful care. And so I'm never quite sure why there's so much controversy about the idea that we want to talk with them first. So one of the most important things about certain diagnoses is that you make them not by speaking to the patient necessarily, but by speaking to those who are in close contact with them. For example, you could find someone describe their ex-partner as a raging narcissist, but the person in question would think they're perfectly okay and not see a problem. They would not report anything as wrong. And why am I saying this? Because I worked in GIDS at the Tavistock in 2004 and became extremely concerned about the rapid medicalisation of children, where I witnessed certain team members deciding that it would be okay for children to be sent to receive powerful drugs to interfere with their normal, healthy hormonal systems and their physical development. I'm not going to go into the story today of how that unfolded, because I think most of you are aware of the judicial review and the subsequent CAS review, which we're talking about. But when I raised concerns in the GIDS, I discovered that my freedom of thought, connected to really 30 years at that stage of mental health experience, was questioned. I was told to think very carefully about what I was saying and what I was writing in the medical notes. And it eventually led to a sense of being told that I should not have the freedom for clinical thought because it would lead me and the service into trouble. And at that stage, it was largely external forces, but the charities and the trans activism. But it's grown, and I think it's from within the NHS and clinical services all round now. So I left the service, but there was a report after I whistle blew. There was a report, and one of the things that were flagged up was that there needed to be more research, clinical scrutiny, that the GIDS didn't have an ethical framework, and at that time, I'm not sure if they used the word ethical, but they didn't have a clinical framework. But the report was buried and forgotten. So the human mind likes to have certainty. It hates doubt and fear. It tries to disconnect from pain, and that goes for most of us. There are connections I would make between the children who are caught up in a self-diagnosis of their trans identity because they have minds that will not allow them full freedom of thought. And it tends to lead to a censoring of speech, both their own, but importantly, the adults and other family members around them, and the clinicians that they come into contact with. And that's sort of why I mentioned the idea of the importance of a holistic and 360-degree view of the people who present with gender identity issues, particularly the younger people. So working as a psychotherapist, one walks a line between both demonstrating to your patient that you have empathy and some understanding of what they're experiencing, but also one needs a freedom of thought, a part of the mind that can enter into a conversation with your immediate experience with the patient. For example, I might find myself feeling very sad or very irritated, or alternatively hopeless, useless during a consultation. In that situation, I try to link with a third space in my mind that allows a triangulation for me to think about their experience, my experience, and how we might explore and understand these feelings together. It is tentative, cautious, sometimes bold or risky, but a good clinician is watching for the impact of their words on the patient and trying to keep curiosity alive whilst protecting the patient from too much psychological exposure. I believe that a conversion therapy ban, which we'll probably talk about later, to include transgender patients will scare most therapists and clinicians away from attempting this work. One is trying to model a kind of a model of the mind where you're safe to explore and question things in your own mind. So what's gone wrong in this area of medical ethics? Well, so much, but I will stick to my area. The reason the so-called affirmation model, which leads to a collusion of agreement and unquestioning route for the trans-identified person, is so persuasive and convincing for many, in my understanding, is that the patients, their parents and professionals all find it hard to remain emotionally connected when there is severe pain. Psychological distress. You need resilience and support to hold out for curiosity and understanding. So much it's easier to move towards the answer. I'm aware I've got to finish, so I'll just quickly scan through. The reason I'm saying this is important is because I think that there is an ethical problem when there seems to be what is termed an easy answer. And I think what we've got to hold out for is encouraging the patients to feel brave enough to explore and understand what their conflicts are, what their pain is about. The problem is if medication is on offer to children and clinicians, it's so much easier to give in to that. So I'll hold things there and maybe come back to the other points that I had said.
My background is in pediatric nursing, and I have a graduate degree in bioethics. So I have a keen interest in the conversation today around the crisis in medical ethics. I want to start by having a thought experiment. We've all been on a plane before. Flight's getting ready to land. You're watching this great movie, and you have about 10 minutes left in the movie, and you're hoping you get to finish the movie before the flight ends. And you're an accountant. And the flight attendant announces that we have a CPA on the plane. He's got to do a big presentation and he needs some help with a spreadsheet. and you ignore the call because you want to finish your movie. But imagine it's a doctor. He's watching the movie and he's got 10 minutes to finish the movie. And the flight attendant says, we have a medical emergency. We think we have a patient having a heart attack. Is there anybody on the plane that can help? Well, can you imagine if that physician opted to just sit in the chair, finish his movie? And then the next day the news reported that somebody died on a plane and there was a doctor on the plane who didn't make himself known. We rightfully expect our physicians to have a moral obligation. They have a duty. They're duty bound. If you read the Hippocratic Oath, they swear an allegiance, a covenant. They take this do no harm, promise, oath very seriously. Aristotle said that the end of the medical art is health. I say the reason we have a crisis in medicine today and a crisis in medical ethics is we've forgotten the aims and the goals and the ends of medicine. It's always been oriented to health. The psychological health, the mental health, the physical health. It's not been oriented to providing services. It's not been oriented to being driven by activism, advocacy. It's not been oriented to an ideological quest. It's been rooted in do no harm. There was a GP on the panel I was on, in the audience on a panel I was on in this room right before, and she asked, why is it that doctors are behaving badly? And I say it's because they forgot what their job is. They forgot their duty. They forgot the purposes of medicine. Why is medicine considered an art? When I was a nurse, I remember working at the University of California, San Francisco. It's a big teaching hospital. The cardiologists would come in doing morning rounds with the residents and the interns, and the residents and interns would look at clipboards and they'd rattle off data, lab values, chest x-ray results. But the attending physician would say, have you looked at the patient? Have you touched the patient's skin? Are they hot? Are they sweaty? Are they cold? Are they clammy? What's the color of their eyes? Are their lips dry? These are the things that the artist does. The artist explores and imagines and investigates, and it's this whole inquiry that it's not data driven. It's not. So doctors are not service providers, and that's what we see in gender affirmation therapy. I think I'm trapped in the wrong body. I'm a boy who wants to be a girl. Okay, I'll chop off your penis. I'll remove your breasts. Doctors are not technicians. That's what the guy at the auto shop does. And when he changes your oil and rotates your tires, they're not activists. Doctors aren't to overprescribe. They are to treat, to heal, and whenever possible, to restore health, especially in the case of elderly and aging. So first, do no harm. I often recall that I speak to so many people who will say they know that Hippocrates said, do no harm. Everybody knows that, right? Raise your hand if you know that, do no harm. But how many people have actually read the oath? And the oath is thousands of years old. It's less than 400 words. So it's not a challenge to read it. But it's really stood the test of time. And if you look, maybe we can talk about that later, but if you look at the modern ethical theories that are governing medicine, they're woefully inadequate, which is why we have this problem on our hands with gender affirmation therapy only approaches. Thank you.
Okay, so thank you for having me. I'm Margaret McCartney. I'm a GP in Glasgow and I'm an academic at St Andrews University. My research interest is in conflicts of interest in medicine. My long-standing interest has been in overdiagnosis and overtreatment, and you can probably see why I'm interested in this, because evidence-based medicine is my watchword. That's the only reason why I think anyone should pay any attention to doctors is if they make a commitment to talking about evidence and offering information and care for you that's based on evidence. And why is that? Well, if we don't use evidence, we inadvertently harm and kill people. So you may have heard of Dr. Spock, a doctor in the 1960s who sold millions of books worldwide and told patients from a position of kindness and authority that babies were safer when put to sleep on their fronts because any vomit that they brought up would surely therefore not be inhaled. And of course, we now know that that was dangerous and harmful advice, and we tell parents to put their kids back to sleep because they have a lower risk of sudden infant death if they do. There's just an example of what seemed quite sensible and compassionate and caring advice turned out actually to be deadly advice. And that's why I think doctors have to make a very strong commitment to practicing evidence-based medicine, even when it seems counterintuitive, sort of silly, dangerous. I remember learning that screening for breast cancer wasn't actually all it was cracked up to be. And I remember thinking, why? How? And it was a revelation, I suppose, that what seemed to be like quite a straightforward thing, find something early, that will help, actually turned out to be counterintuitive and difficult. So I've been a GP now for quite a long time, and the pattern that I started to notice in the last decade or so was something that I'd felt I'd seen before, and I'd seen before in a different form in terms of anorexia and in terms of self-harm, cutting behaviours. And the pattern was that of young adolescent women hating their bodies and growing up in a society where sexual harassment and misogyny absolutely endemic. The pressure on the way to look or to be or to feel as a female was just oppressive. And I felt as though there was something very similar happening in what was the phenomena of young women in particular saying that they hated their bodies and they wanted to identify as male, or they were a male, or they were really a boy. And I was really frightened by this because I didn't know how to understand it, and it seemed to be following a pattern I'd seen before. And I looked to the literature to see what was going on and what was happening. Now, in medicine over the last decade or so, there's been a strong tradition of patient partnership, and much of that has been fantastic. Patients come to an arrangement with doctors, you have discussions about the evidence, try to help each other. What are the questions that patients have? How best should we answer them? But something quite different was happening here, in that I was being told what to think by various lobby groups who had inserted themselves into various aspects of medical institutions and organisations, but critically didn't have an evidence base that I could go back and check and find out whether what they were saying was actually true or not. And the message was that if I didn't immediately affirm individuals as being in their chosen gender, I was actively doing harm. Now, most people go into medicine because they want to do good things, and the idea that you might be causing harm to your patients by your attitude is really quite frightening. And when I came to this originally, I was concerned about it, and then I became quite angry and upset about it when I discovered that the Royal College of GPs had taken £11,000 from an organisation who put an educational platform into the RCGP learning website that said if you don't immediately affirm people in their chosen gender, you will be contributing to harm for them. And I was so outraged about this and the lack of evidence for it. It did eventually get removed, but it was quite a bruising experience. And at that point, I realised just how many people had some awareness that there wasn't much evidence going on here. There may well be harms that are going on, but we're afraid to speak up. Now, I have written for a long time in the lay press, and I always consider it a privilege to be published and not a right. But for the first time in my professional life, the usual left-wing outlets I would quite often write for would not accept anything questioning or raising issues or concerns in this. And that made me even more frightened because I was worried that we were making a category error. I've written a paper which is freely available in the British Journal of General Practice about what we've termed delicate diagnoses, which are diagnoses that occur in society, but which are massively influenced by what's going on elsewhere. So pharmaceutical lobbying groups, provision of private practice, single issue groups. I'm sure you can think of lots of areas of medicine which fall into these categories and where diagnostic rates and the treatments that we offer for them are not predicated by what's the evidence on something, but it's predicated by what's happening externally, the pressures that put on doctors to prescribe. I'm going to close over because I saw that yellow card. But in general, I kind of disagree a bit. I don't think we've forgotten ethics. I think that the problem is that doctors are being filtered through this message that the ethical thing is to go around the gender affirmation and treatment route. They're kind of hearing that that's the ethical thing to do. But I think we need to raise the evidence hand and say, well, actually, the evidence is telling us something very difficult and very different. I believe that most people in healthcare are trying to do their best. There's always going to be bad actors. But I do believe that the majority of people out there do have similar concerns and are finding it hard to raise them. And I see my job here as trying to support people to raise concerns in helpful and constructive ways so that we can get people the care and attention that they need and which is evidence-based. Thank you.
Hi there. I'm Stella O'Malley, a psychotherapist and director of GenSpect. And I suppose I do think mental health has really lost its way in many ways. It's not just gender dysphoria. Gender dysphoria has revealed a real distress in the heart of the psychological industry, which is what it's become, and the well-being industry. And I think it's very important that we realise how difficult anybody who gets into the caring professions, whether they're a doctor, a psychiatrist, psychotherapist, how helpless we feel in a world that is seeking certainty and diagnosis and frameworks and treatment paths and a result, to be faced with the helplessness of some people are very difficult to help, and some people don't seem to be able to be helped. And what do we as a world do about that fact? Hopefully we don't fall into the many examples we've seen here of unethical treatment. But that is, I think, very often the reason why so many people who are in psychiatric professions who do fall into unethical treatment, because they want to help. And I saw a man on the way here, and he was clearly extremely distressed. Like, really, it was kind of horrifying to watch it. And you could see anybody who was walking by didn't quite know what to do. One person got out their phone and started filming. And in a way, you lighten it because you don't know what to do. That utter sense of helplessness in the face of profound mental distress that nobody has figured out what to do. But we are living in a world that's very results orientated, and all the kind of all the services are around the results, and we have got ourselves into a really difficult situation where people are seeking results, and if there isn't results, who's to blame? And so when we look at that and we realise what we're doing to people who are very, very in deep distress and they need help, we need, I suppose, as a profession, whether a psychiatrist, psychotherapist, psychologist, nurse, doctor, we need to start to have the freedom to say, I don't think I can help this person. I don't know who can. I don't think I can. And when we've got the courage and the moral courage to do that, it'll free things up a little bit. But it's going to be devastating for the people who are the recipients of this. And that's not what's happening these days. Instead, people are getting bounced from one person to the next person, from one service to the next service. And that's a real kind of moral conundrum that we are facing, that we need to look at and think, well, that's actually what we need to face. The fact that people are coming to us and we don't know what to do and we're helpless in a world that says you're not allowed to say those sentences. And so I kind of think we do have to lean into that. Maybe the battle of ideas will lean into it. But I do want to kind of give a shout out of some of the other scandals we've lost our way in the psych professions before. An obvious one would be multiple personality disorder, where, in a time of huge sexual politics in the 1980s and 1990s, there was a kind of a theory, because psychiatry is generally, clusters of symptoms. It's a very incoherent discipline. It's clusters of symptoms, and then there's a theory in hindsight laid onto this cluster of symptoms, be they depression or anxiety or schizophrenia or whatever they are. And so this recovered memory therapy was based on the idea that children had sexual abuse, but they'd completely forgotten about it. And then they had multiple personality disorder later on. And there's an interesting psychiatrist, he's still alive, he's 93, called Paul McHugh. And he had chased John Money around Johns Hopkins Hospital from kind of 1966 to 1978, because he noticed that John Money, who is a disgrace, and I urge you to look him up if you don't know who he is, he was performing and creating this entire clinic and industry around transsexual, at the time it was called, transsexual surgeries. And Paul McHugh was realising that these people were not improving. They were deeply disturbed, very, very mentally ill people who were not improving. And so he followed it, and in the end he got Johns Hopkins closed, and it closed in 1978 as a result of the very bad results of these people who had trans surgeries and did not improve. They just had other sicknesses. By the way, later on it reopened in 2014. But Paul McHugh then went on to become involved with multiple personality disorder, and he was part of the foundation of the false memory syndrome. And he kind of highlighted the idea that this kind of idea of recovered memory was a very dubious theory of people faced with deep distress, and they brought in a theory. And I would say it's very similar to the trans theory insofar as we could easily have false identity syndrome. And we could easily start kind of looking into this. This is a false identity. It's a syndrome. It's a cluster of symptoms. And I could easily bring up a theory. Any one of us could bring up a theory. I've got the red card. But what I'm trying to do, I suppose, more than anything is, yes, we know there have been many, many medical scandals, psychiatric scandals before. And what we have to do is start facing the fact that sometimes we can't help. And we have a real dilemma on where we go from there.